Hey, it's Professor Rich, and this is Module 3, Pain and Inflammation PowerPoint. To go through the content outline, we're going to look at pain management, CAM, connective tissue disorders, including osteoarthritis, rheumatoid arthritis, scleroderma, lupus, gout, and fibromyalgia. So, overview of pain. Effective pain management includes the use of pharmacological and non-pharmacological pain management therapies. Clients have a right to adequate assessment and management of pain. Nurses are accountable for the assessment of pain. Professional organizations like the Joint Commission have mandates requiring pain assessment and management. The nurse's role is that of an advocate, a member of the healthcare team, and an educator for effective pain management. Nurses have a priority responsibility for the continual assessment of the client's pain level and to provide individualized interventions. Depending on the setting and route of the analgesia administration, the nurse might need to reassess the pain 10 to 60 minutes after administering the pain medication. Assessment challenges can occur with clients who have different cognitive impairment, who speak a different language, or receive prescribed mechanical ventilation. So a focused pain assessment. So location. So we're going to use the anatomical terminology and landmarks to describe the location. So we're going to ask, where's your pain? Does it radiate anywhere? Ask your client to point to the location where they have pain. Quality. This refers to how the pain feels. Is it sharp, dull, aching, burning, stabbing, pounding, throbbing, shooting, gnawing, tender? Do they feel tight, heavy, tiring, exhausting, terrifying, torturing, nagging, annoying, intense, unbearable? So you're going to ask, what does the pain feel like? And you might need to give them some examples, like, is the pain throbbing? Is the pain burning? To get a better assessment. Measures. So this is the intensity, strength, and severity. So these are the measures of pain. So you're going to use a visual analog scale, maybe. Those could be like the FACES scales, a description scale. You could use a number rating, so 0 through 10. So you want to measure the pain, monitor it, and evaluate the effectiveness of your interventions. So you're going to ask, how much pain do you have now? What is the worst or best your pain has been? Rate your pain on this scale. Is it better? Is it worse? So that's kind of how we're going to measure it. Timing. So this is the onset of the pain, the duration, and the frequency. So when did it start? How long does it last? How often does it occur? Is it constant or is it intermittent? Setting. How does the pain affect daily life? Or how activities of daily living affect the pain? So where are you when your symptoms occur? What are you doing when these symptoms start? How does the pain affect your sleep? How does the pain affect your ability to work, to do your job, or any activity of daily living? Associated manifestations. So we're going to document, like, are they, is it making them feel fatigued? Is it making them depressed? Are they nauseous? Are they getting anxious from it? So what other symptoms do you have when you're feeling this pain? Also with that, what are the aggravating or relieving factors? So what makes the pain better and what makes the pain worse? Also ask, are you taking any prescription, herbal, or over-the-counter medications? These are all important parts of our focused pain assessment. So again, with the assessment of pain. So first off, pain is whatever your client or the person experiencing it says it is. And it exists whenever that person says it does. So your patient can be there, eating their potato chips or whatever else and telling you they have 10 out of 10 pain. That's what they say they have. That's what they have. So the client's report of pain is the most reliable diagnostic measure of pain. Self-report using standardized pain scales is useful for clients over the age of 7. Specialized pain scales are available for younger children and other clients who are unable to self-report their pain. There are a variety of pain scales that feature images, numbers, intensity indicators, and descriptive words, also various languages. Assess and document pain. Remember, this is the 5th vital sign. You want to document it according to the client's condition and the agency's guidelines. Use that focused pain assessment to obtain subjective data. Remember, pain is subjective. It's whatever the client says it is. These are just a couple scales. So I know PQRST is often talked about. And then there's also your number scale, and they also have that FACES scale, the Wong-Baker FACES. So risk factors for undertreatment of pain. So this could be cultural and societal attitudes, lack of knowledge, patients' fear of addiction to pain medications, exaggerated fear of respiratory depression or overdose. And then there's also the populations at risk for undertreatment of pain. So this is going to be your infants, young children, older adults, and then clients who have substance abuse disorders. So the pain experience factors. So there's different things that affect how we experience pain. So infants, obviously they can't verbalize their pain, but they also can't understand their pain. Same idea with older adults. They might have multiple pathologies causing the pain and limiting function. Not all people or older adults can actually, tell you about their pain. Fatigue. So fatigue actually increases sensitivity to pain. Genetic sensitivity. So genetics can increase or decrease pain tolerance. Cognitive function. So clients who are cognitively impaired, they might not be able to report their pain, or maybe they can't report it accurately. Prior experiences can increase or decrease sensitivity depending on what clients obtained or whether clients obtained adequate relief from that pain. Anxiety and fear, those can increase sensitivity to pain. Support systems can decrease sensitivity to pain. And culture can influence how the client expresses their pain or the meaning that they give pain. So all these different things kind of affect the patient's experience with their pain. Types of pain. So pain is categorized by duration. So is it acute or chronic? And it's also by pathology. Is it nociceptive or neuropathic? Clients can experience pain that is mixed and difficult to categorize. Conditions that cause mixed pain, a few are fibromyalgia, HIV, and Lyme's disease. Breakthrough pain. So this occurs when a client experiences an exacerbation of acute pain. Clients who have chronic conditions can experience episodes of breakthrough pain requiring additional pain relief measures. So they might be taking something around the clock, but that's just not helping enough. So they have to take something for this breakthrough pain because the pain, for whatever reason, they have that acute on chronic pain. So they need something a little bit more during that time. Acute pain. So pain, again, it can be acute or chronic. So acute pain is protective, it's temporary, it's usually self-limiting, and it resolves with tissue healing. Physiological responses are common, usually the sympathetic nervous system. This is our fight or flight response. So the patient may have tachycardia, hypertension, anxiety, diaphoresis, muscle tension. Behaviorally, we might see grimacing, moaning, flinching, maybe guarding. The nurse should be aware that a client not exhibiting those physiological or behavioral responses does not mean that the pain is not there. So your patient can have a normal blood pressure and everything else, but telling you that they have 10 out of 10 pain. Interventions include treatment of the underlying problem. So obviously an injury, wounds, surgical incision, these are different things that can go to or contribute to acute pain. Chronic pain. So this is not protective. This occurs frequently. It lasts longer than 3 months, and it persists beyond tissue healing. So physiological responses do not usually increase vital signs. The client's vital signs can actually be lower than normal in response to a chronic pain. These clients often have depression, fatigue, decreased level of functioning, or disability. Chronic pain might not have a known cause, or it might not respond to intervention. Chronic pain can be classified as chronic cancer pain or chronic non-cancer pain. The pain associated with osteoarthritis and neuropathy are examples of chronic non-cancer pain. So causes of pain, acute and chronic. So we have trauma, surgery, cancer, arthritis, fibromyalgia, neuropathy, diagnostic or treatment procedures. So this could be your injections, intubation, radiation. So all these different things can cause acute or chronic pain. Nociceptive pain. So this arises from damage to or inflammation of tissue other than that of the peripheral and central nervous system. So nociceptive pain is a result of the activation of normal processing of pain stimuli. It involves transduction, transmission, perception, and modulation of impulses generated by nociceptors located throughout the body. Stimuli following tissue damage from cuts, burns, tumor growth, or chemicals trigger these nociceptors to send a message to the nervous system. It's usually throbbing, aching, and localized. The pain is managed using opiates and non-opiate medication. So the different types, so there's somatic, so this is in bones, joints, muscles, skin, or connective tissue. And then there's visceral, which is our internal organs such as the stomach or intestines. This can also cause referred pain in other locations of the body separate from the stimulus. Neuropathic pain. This is also known as nerve pain. So this comes from abnormal or damaged pain nerves. So it differs from nociceptive pain in the sense that it's abnormal processing of painful stimuli. Neuropathic pain is caused by changes in the peripheral or central nervous system. So peripheral sensitization, I don't know why that's so hard to say, sensitization, changes in ion channels, and neuroplasticity are peripheral nervous system changes that contribute to this neuropathic pain. Neuroplasticity occurs when nerve endings are damaged and reorganized in an abnormal manner. Central nervous system changes that lead to neuropathic pain include an increase in the excitability of the central neurons, an increase in the release of and binding of neurotransmitters, and the reorganization of nerves following injury. All of these alter or increase pain sensations. So a good example of this is phantom limb pain. We'll talk about this more in Module 9 when we talk about amputations. But so phantom limb pain is basically a patient saying that they have pain in their foot, but they have a below the knee amputation. So also pain below the level of a spinal cord injury, and also diabetic neuropathy. Neuropathic pain is usually intense, shooting, burning, or it can be described as pins and needles. This pain typically is managed using adjuvant medications like antidepressants, antispasmodic agents, and skeletal muscle relaxants. So management of pain. So we want to incorporate pharmacological and non-pharmacological strategies into the plan of care. Consider the client's preferences. Discuss the use of the complementary and alternative practices, that CAM. Assist the client to set a pain relief or comfort function goal and refer back to that goal when you're planning and evaluating pain interventions. Determine the client's need for scheduled analgesia, such as for chronic or post-op pain. Around-the-clock scheduled medication is better than just PRN medication. Plan to pre-medicate the client prior to painful procedures. So this could be repositioning, wound care, an invasive diagnostic test. Refer to dosage charts that describe and compare the potency of various pain medications. This could be comparing morphine to Dilaudid. They say Dilaudid is 7 times as strong as morphine. Non-pharmacological pain strategies. So we want to help improve coping by relieving stress associated with pain. So these strategies assist the clients in reducing the amount of pharmacological interventions for pain and are particularly helpful when the client cannot take pain medications. So the client might choose non-pharmacological, complementary, and alternative measures to manage pain. So there's mind-body practices like yoga, chiropractic manipulation, cognitive approaches like meditation and distraction, and natural products like herbs and oils. And we'll talk more about this in a minute. So pharmacological interventions. Analgesics are the mainstay for relieving pain. The parenteral route is best for immediate, short-term relief of acute pain. The oral route is better for chronic, non-fluctuating pain. Treatment tools such as the WHO analgesic ladder suggest administering non-opiate analgesics first and progressing through weak opiates, then to stronger ones to manage pain. Expect to administer IV analgesics immediately post-op and to transition clients to oral medications as pain is managed properly through the post-operative period. When transitioning clients from IV to oral analgesia, a larger dose is required for oral dosing because the full dose of medication does not reach the bloodstream. Clients experiencing acute pain receive doses that are gradually titrated down until they can be comfortable without medication or at a minimal dose. The three classes of analgesics are non-opiates, opiates, and adjuvants. Non-opiate analgesics. So these are appropriate for treating mild to moderate pain, and they're often added to opiates for treatment for more intense pain. That'd be like your Percocet, which is your acetaminophen and oxycodone. So non-opiate analgesics often have antipyretic and anti-inflammatory properties. Non-opiate analgesics are often prescribed following painful procedures. Acetaminophen is most often used alone or in combo with other medications. Ensure the total amount of acetaminophen does not exceed 4 grams a day. It is safe to administer acetaminophen concurrently with NSAIDs like ibuprofen. Opiates. So opiates are appropriate for treating moderate to severe pain. The term narcotic is not synonymous with opiate analgesics and should not be used because narcotics also refer to illegal substances like cocaine. Opiate analgesics for moderate pain include tramadol, hydrocodone, and codeine. Hydromorphone, fentanyl, morphine, oxycodone, and methadone are effects for more severe pain. Morphine is the opiate most used, and other opiate effects are compared to the effects of morphine. You want to check opiate formulations carefully to determine whether a short-acting or modified release, also known as extended release, is indicated. For many opiates, the dose can be titrated upward progressively until the client experiences pain relief. However, upward titration increases the risk for adverse effects. Opiates are available in transdermal, transmucosal, and buccal routes. It is essential to monitor and intervene for adverse effects of opiate use. So these adverse effects could be constipation. So we want to use a preventative approach. So we're going to monitor bowel movements, fluids, fiber intake, encourage exercise, stool softeners, maybe use stimulant laxatives or enemas. Orthostatic hypotension. So we want our clients to dangle or sit at the bedside prior to standing. We want them to sit or lie down if they're lightheaded or dizzy. Instruct your client to use, to avoid sudden changes in position by slowly moving from lying to standing. We want them again to sit or dangle in between. We want to provide assistance with ambulation. Monitor for urinary retention, so we're going to monitor I's and O's, assess for any distension, catheterize if needed. Nausea, vomiting, so we might administer an antiemetic like ondansetron prior. We might give crackers prior. We want our clients to kind of hang out and not move too quickly. We want to eliminate odors from the room if they're going to have that nausea. And then a big thing is sedation. So we want to monitor the level of consciousness and take safety precautions. Sedation usually precedes respiratory depression. Respiratory depression, so we want to monitor their their respiratory rate prior to and following the administration of opiates. The initial treatment of respiratory depression and sedation is generally reduction in opioid use. If necessary, we will administer naloxone to reverse opioid effects. So that's our Narcan. Adjuvant medications. So these, they enhance the effects of non-opiates. They help alleviate other manifestations like depression, seizures, and inflammation. And they're useful in treating neuropathic pain. So we have anticonvulsants, anti-anxiety medications, antihistamines, glucocorticoids, antiemetics, and anesthetics like ketamine. Patient-controlled analgesia, known as PCA. So this is a medication delivery system that allows clients to self-administer safe doses of opiates. Its small, frequent dosing ensures consistent plasma levels. Clients have less lag time between identified need of medication and the delivery of the medication. This increases their sense of control and usually decreases the amount of medication they need. Morphine and hydromorphone are the typical medications used in PCA pumps. Clients should let the nurse know if the pump is not controlling the pain. To prevent inadvertent overdosing, the client is the only person who should push the PCA button. Other pain management strategies are implantable pain pumps, medication injections and short-term infusions, a local infiltration into a wound, regional infusion to block a group of nerves, also known as a nerve block or epidural infusion, stimulation of brain and spinal cord, nerve ablation and cryoablation procedures. And then there's chronic pain interventions, which are strategies specific for relieving chronic pain. So that's all the above interventions plus administering long-acting or controlled release opiate analgesics. And this includes transdermal route, like a fentanyl patch. Administering analgesics around the clock rather than PRN. Referral to accredited pain management centers. They offer holistic approaches to pain management. Referral to palliative or hospice treatment centers as indicated based on the case of pain. Complications. So, under treatment of pain, this is a serious complication and can lead to increased anxiety with acute pain and depression with chronic pain. Assess the clients for pain frequently and intervene as appropriate. And then overdosing. So sedation, respiratory depression, and coma can occur as a result of overdosing. Sedation always precedes respiratory depression. So sedation's first, respiratory depression comes after. Identify high-risk clients, so usually older clients. Carefully titrate doses while closely monitoring their respiratory status. Stop the opiate and give the antagonist Narcan if the respiratory rate is below 8 per minute or shallow, or the client is difficult to arouse. The nurse should closely monitor the client following administration of Narcan. So the duration of opiates can outlast the duration of Narcan, meaning that okay, you have a patient that has an overdose, you give Narcan, your patient wakes up, okay, and then all of a sudden they're back to respiratory depression because the effect or the half-life of that opiate is longer than the Narcan. So the Narcan's already worn off, but that opiate is still very much in their system. So you might need to give additional doses of Narcan. Patient might even need a Narcan drip and go to the ICU. Identify the cause of sedation. Make sure you use the sedation scale in addition to pain ratings to assess the pain, especially when administering opiates. If you do clinical at Banner, when you monitor pain, it will ask you if an opiate was given or not, and then you will have the sedation scale. If the opiate was given, they'll also request the sedation scale to be used. Okay, so to just go back to CAM a little bit, so complementary and alternative medicine. This is a collection of old world traditions and healthcare practices that have been handed down through generations. The therapies and products that are recognized as CAM are rooted in ancient wisdom, traditions, folklore, and religious and spiritual practices. These traditional practices and doctrines are based on theoretical foundations and are performed by licensed and specially trained practitioners. The goals of CAM include promotion of wellness, the prevention of illness, and a reduction in treatment side effects, improvement of the immune system, and enhancement of quality of life. Although these goals of care are not unlike those of conventional medicine, CAM healthcare practices are considered outside the sphere of conventional scientific methodologies, hence the term alternative and unconventional as an approach to medical treatment. The term complementary refers to practices, treatments, or modalities that are standalone therapies or therapies that could be paired with conventional medicine to modify, restore, or renew balance, ease symptoms, or improve quality of life. The NCCIH classifies CAM according to specific techniques, methods, and applications. 5 categories of CAM are: 1. Whole medical systems, alternative medicine systems. 2. Mind-body therapies. 3. Manipulative and body-based therapies. 4. Energy healing therapies. And 5. Dietary supplements and botanical herbal medicine. Treatments are personalized according to the physical, emotional, spiritual, religious, nutritional, and environmental needs of the patient. They are helpful in the management of emotional and psychological disorders such as chronic fatigue, stress, anxiety, depression, and symptoms related to menopause, sleeping problems, or insomnia. They are also helpful in the management of pain caused by arthritis, osteoarthritis, fibromyalgia, chronic back pain, carpal tunnel syndrome, migraines, sports injuries, and neuropathy. So different examples. So Ayurvedic medicine is a natural medical system that originated in India. It uses a combination of herbs, yoga, massage, and diet to restore balance and wellness. Traditional Chinese medicine, also referred to as acupuncture, is the oldest and most continuously practiced medicine in the world. The goal of treatment is to sustain the balance or flow of qi. Qi is defined as the universal life force or personal life force and is considered the connecting energy that influences all living, non-living things. The flow of qi is facilitated by the acupuncturist's point placement of small needles, which are inserted just under the surface of the skin. Now, naturopathy is a 100-year-old practice that integrates natural therapies such as acupuncture, hydrotherapy, manipulative therapy, homeopathy, and botanicals. Native American medicine is a collection of indigenous customs, beliefs, and practices. Meditation is self-directed technique used to quiet the mind and relax the body towards peace and calmness. This is achieved by closing the eyes and creating a sound or chanting. Methods include mindfulness meditation or practice of focusing on the present moment. Transcendental meditation or the repetition of a word or sound that has special meaning. Breath meditation, which focuses on the process of inhaling and exhaling. Prayer and spirituality. Yoga. This is an example of a mind-body practice that incorporates breathing techniques, body movements, forms of exercise, diverse postures, meditation, and sometimes chanting. Imaging and guided imagery. Tai Chi. This is an ancient form of Chinese exercise that is considered a martial art. Zero balancing. The final example in this classification is ZB. Zero balancing uses skilled touch to address the relationship between the energy and structures of the body. This focuses primarily on specific skeletal joints that conduct and balance forces of gravity, posture, and movement. Massage therapy, chiropractic medicine, osteopathic medicine. Osteopathic medicine is a process of using one's hands to manipulate and palpate soft tissues, muscles, and bones, moving them in specific ways to bring the body back into optimal function and restore health. A unique form of body manipulation is reflexology. Within this specific type, it is believed that the body is divided into zones that are located in precise areas along the soles of feet, hands, and ears. Practitioners use various forms of pressure, touch, and manipulative techniques directed towards the zone or zones that need to affect physical change. Therapeutic touch or healing touch is a contemporary intervention of several ancient healing practices, and it is consciously directed process of energy exchange during which the practitioners use their hands to focus and facilitate healing process into someone who is ill. Reiki disseminates energy along the centers and pathways of the body as a means of manipulation, and it manipulates the energy fields to restore health and well-being. We have dietary supplements, so this is the most common type of alternative modality, and it's used to support the immune system, improve memory, aid digestion, decrease nausea, alleviate cold symptoms, reduce stress, reduce menopausal symptoms, decrease arthritic pain, support heart health, enhance condition of skin and hair. Mineral vitamins, hormones, and diet-based therapies are also included in this category. Herbal medicine and botanicals. So these are products that originate from natural plant sources like flowers, seeds, stems, and fruits. The end of this slide. And we're going to keep going. So as CAM continues to grow in popularity, it is vital that nurses be knowledgeable about the usefulness, safety, and appropriateness of CAM in order to guide patients through the labyrinth of Western medicine and complementary health choices. Individuals are seeking value-driven partnership and rapport related to the overall healthcare needs, and CAM supports that need as defined by the guiding principles of partnership, wellness, and the energy models. A thorough assessment of the patient's attitudes related to CAM is an important first step in establishing a baseline holistic health assessment and building rapport with the client and family. Possessing an accepting and respectful communication style will enhance the effectiveness of the assessment and help build a trusting partnership. Understanding the goals of care and how the patient will benefit from CAM is another component needed in building a foundation for competent, safe nursing care. Clients have constant access to CAM information via the internet and popular press or through word of mouth. It is the responsibility of the nurse to ensure that the client has an understanding of the principles of CAM, the reasons for choosing CAM, and how the integration of therapies into their plan of care may benefit them. Providing and assisting individuals with finding accurate and reliable websites, well-written reading material, and documented evidence-based research will help them and their family members make well-informed choices. Other information that is vital for patients is how to choose a CAM practitioner. Before treatment, patients may wish to interview CAM practitioners and review their qualifications and credentials. In the book on box 12.4, there's a guide to assist clients in finding a qualified and skilled CAM practitioner. So providing the patient with a list of provider questions that can help them ensure that they receive the correct treatment and that the therapist or practitioner is qualified. Okay, so osteoarthritis, so getting into our diseases. So risk factors are going to be age, female sex, obesity, occupation. So osteoarthritis is a disease that affects the joint as a whole. This is because of biological, chemical, or viscoelastic changes within the joint. Cartilage serves to provide the joint protection by providing a smooth surface on which the bones glide and disperse loads across the joint. When the cartilage is damaged from major trauma or just repetitive microtrauma, osteophytes are formed by the body in an attempt to repair that damage. Osteophytes are projections of new cartilage and bone growth that form along joint lines, and they contribute to pain in the joint and decreased range of motion. Cartilage loss is a clinical feature of osteoarthritis, causing the bone to be unprotected, which leads to the deterioration of joint function. Clinical manifestations of osteoarthritis include progressive pain over time, decreased range of motion, tenderness to touch over the joint line or around the joint, bony swelling, soft tissue swelling, deformity, and instability, Crepitus, which is a crackling, grating sound or feeling due to air or gas under the skin. This can also be present. This is due to cartilage breakdown in the joint. So patients typically experience more pain with activity, which improves with rest. So that's classic for osteoarthritis. So more pain with activity, that improves with rest. This nurse may identify the following: unsteady gait, bony enlargements, or swelling of the affected joint. Osteophyte formations on the proximal interphalangeal joints are Bouchard's nodes, and distal interphalangeal joints are referred to as Herbertin's nodes. Herbertin's nodes, so they actually have that picture on this slide. But this also, here, I'll circle it right there for you. This, like when you have that old lady with like the knobby fingers, that's what these are. Fatigue, painful range of motion of the affected joints. One second. So they'll have an elevated serum creatinine. This is often due to NSAID use. Elevated liver enzymes can happen because of this. Constipation if they're using opiate analgesics. And they probably have decreased physical activity because they're hurting. Diagnosis. So this can be made based on clinical manifestations without lab testing or radiographs. If a patient is 45 or older and presents with persistent usage related to pain in several joints and morning stiffness that lasts less than 30 minutes. Laboratory testing can be used to rule out other diagnoses like RA. It should be conducted as part of the medical management to monitor any side effects of medication use. Plain radiographs of the affected joints, such as hands, hips, knees, spine, along with a history and physical, are usually used to confirm that diagnosis. So evidence of osteoarthritis, so this is joint space narrowing, subchondral sclerosis or cysts, and the presence of osteophytes. So that's what they'll see on those radiographs. Non-pharmacological therapies, so this is going to be weight loss if it's indicated. So if someone's overweight and they have osteoarthritis, let's say in their knees, if they lose weight, it could help. Heat or cold compress applications, aerobic exercises, physical therapy. This can include range of motion and muscle strengthening exercises. The use of ambulatory assisted devices, appropriate footwear. This might be like a lateral wedge insole, depends on what their issue is. Occupational therapy, joint protection, energy conservation, and if they need assisted devices for their activity of daily living, maybe they need a walker or a cane to help support them. It's also important to educate your patient on self-management programs and social support. Pharmacological, so Tylenol or acetaminophen is very often used for mild to moderate pain. Again, make sure that their dose doesn't exceed 4 grams daily. Also ask your patient if they have any history of liver disease, because we don't really want to be giving them Tylenol if they have a liver issue. Patients with more severe pain, we might additionally add NSAIDs like ibuprofen to that. We also might need to do intra-articular injections. So this is like a corticosteroid that would go right into the joint. We could use them all together, the acetaminophen, ibuprofen, and that intra-articular medication. NSAIDs do come with the increased risk of bleeding, gastric ulcers, and risk of renal damage. Opiates are an option, but we want to use them sparingly because of the habits that they can form. Surgery might be needed. They might need an arthroscopy. So if someone needs a knee replacement or hip replacement, they'd have that arthroscopic joint. They might need that replacement. They might need debridement, synovectomy. So this can negatively affect a patient. Obviously, it could also increase the risk of different conditions like diabetes and heart failure, because they'll have that decreased ability to exercise if they have this. I do want to say, so these are often non-symmetrical because it's from overuse of a joint. So if you maybe overusing like your right hand because you're texting a million times with your right hand, like you're going to have an issue with your right hand, not your left. So this is usually not symmetrical. Rheumatoid arthritis. So I'll start by saying this is symmetrical. So rheumatoid arthritis is chronic, systematic, autoimmune inflammatory disease, and it's characterized by an inflammatory process that affects diastrodal or free-moving joints. It causes pain and swelling. The involved joints are usually distributed in a symmetrical fashion, meaning bilateral wrists, bilateral ankles, or bilateral knees. Rheumatoid arthritis primarily targets the synovial membrane. The exact pathophysiological or the exact pathophysiology is unclear. However, it is known that an unknown antigen triggers an immune response, leading to synovial tissue damage. The immune system essentially fails to distinguish self from non-self and causes destruction of the synovium of the joint. So the body is basically attacking itself. Inflammation of the synovium may lead to dramatic increase in synovial fluid, impairing movement and causing pain. The synovial membrane becomes thickened and promotes the destruction of the joint. 1% of the population has this. It affects females more than males. Environmental factors like cigarette smoke, bacteria, and viruses have been implicated as initiating factors for the development of RA in the genetically predisposed population. Clinical manifestations include joint pain, joint swelling, erythema, morning stiffness, and fatigue. Onset is often insidious with vague complaints of joint and muscle pain that evolves into joint pain with synovitis, inflammation of the synovial membrane, and can lead to destruction of the joint and deformity. Rheumatoid arthritis, if left untreated or inadequately treated, leads to irreversible joint damage and disability. Common joint deformities include swan neck deformity caused by hyperextension of the proximal interphalangeal joints, boutonniere deformity caused by abnormal flexion of the proximal interphalangeal joints, and ulnar deviation caused by lateral deviation of the phalanges. The nurse may identify the following in their patients: unsteady gait, bony enlargement or swelling of affected joints, warmth and redness of joints, painful range of motion of affected joints, increased incidence of infection, elevated serum creatinine secondary to NSAID use, elevated liver enzymes secondary to the use of methotrexate, constipation secondary to decreased physical activity and or use of opiate analgesics, nausea and oral ulcers related to methotrexate use, cough and or shortness of breath due to interstitial lung disease, which can be caused by RA or by methotrexate therapy, a self-care deficit. Diagnosing RA is a process that may involve more than one evaluation by a rheumatologist. RA is diagnosed by combining clinical manifestations, laboratory values, and radiographs or ultrasound. Lab testing is non-conclusive, but is done to help with diagnosis and to monitor for side effects of the medication used. The presence of the antibodies, rheumatoid factor, and anti-cyclic citrulline peptides may assist in the confirmation of the diagnosis. But the absence of these does not exclude the diagnosis because approximately 25 to 30% of patients are negative for these antibodies. A positive rheumatoid factor does not always indicate RA. There are other autoimmune factors that have a positive rheumatoid factor. Acute phase reactants such as the CRP, the C-reactive protein, and the erythrocyte sedimentation rate, ESR, may be used to detect inflammation, but they are not RA specific. Radiographs, so conventional radiographs can be used for bony erosions and joint space narrowing. They might need to be repeated during use to assess disease progression or effective effective pharmacological therapy. MRIs might be used to detect erosions if they're not detected by the regular X-ray. And ultrasounds might be used to look at the synovitis and the synovial fluid. So treatment. So there's the non-pharmacological therapy. Education is very important in the management of this. Patients need to understand the disease and the measures that they can take to help manage the disease. So range of motion exercises, these promote joint mobility and reduce stiffness. They improve muscle strength. Aerobic exercises to promote cardiac health. Physical and occupational therapies might be necessary to teach patients appropriate exercises, teach patients how to protect their joints. We need to evaluate the need for assistive devices and teach the proper use of them. Proper nutrition is important. They need to maintain good health, prevent obesity, and decrease the risk of heart disease. It's important for patients to take rest periods and to manage their fatigue and joint pain. Pharmacological therapy. So the goal of pharmacological treatment is to control the inflammation that leads to the joint pain and the tissue destruction decreasing, So we want to decrease joint pain, decrease the inflammation of the synovium. We want to decrease stiffness, maintain joint function, and prevent any joint destruction. So treatment decisions are based on the disease severity and the response to medications. So initial treatments can include analgesics like NSAIDs and glucocorticoids. The analgesics could be Tylenol, NSAIDs, it could be opioid use. We want to provide pain relief with no alteration in the disease process. But then anti-inflammatories, these will be used to reduce inflammation. So those are ibuprofen. We might use glucocorticoids like prednisone. They could be given orally, intramuscularly, into the joint itself or IV. They suppress inflammation and alter the disease process, but they're not really safe for long periods of time or in high doses. Patients with RA, so these, if their disease is not responding well to a combination of the analgesics, anti-inflammatory, and low dose like prednisone, they could be treated with disease-modifying anti-rheumatic drugs. These are called DMARDs, D-M-A-R-D-S. So these include like methotrexate, leflunomide, hydroxychloroquine, that's also called Plaquenil, sulfasalazine, and tafositamab. So these alter the immune system in various ways. They alter the inflammatory response to decrease inflammation, and they slow disease progression. These medications can be used alone as monotherapy or in conjunction with other medications. Before starting DMARDs, patients should inform their healthcare provider if they have a history of or active tuberculosis. Many patients respond well to methotrexate, which is the first-line DMARD, and that is the treatment of choice for RA. Methotrexate is taken once a week orally, subcutaneous or intramuscular, but it's only once a week. Surgical intervention, so this includes joint replacement. Fusion might be necessary to help alleviate pain. They may choose to have surgical removal of their rheumatoid nodules, but they may return over time, so some patients opt not to do that, or most patients, honestly. There's a lot of complications with RA, so uncontrolled disease or a result of pharmacological therapy. Patients can develop decreased function of their joints, permanent joint deformities. This can lead to permanent disability. Extra-articular complications such as increased risk of infection, risk of developing cancer. So that wraps up RA. Scleroderma. So this is not considered a hereditary disease, but patients who have first-degree relative scleroderma are more susceptible to developing the disease than the general population. It has also been suggested that as in other autoimmune connective tissue diseases, Environmental exposures to infectious agents and occupational toxins can play a role in triggering this disease. Scleroderma is a very complex disease that not only affects the skin, but also can involve internal organs. The exact cause is unknown. It is believed to be autoimmune disease caused by many external triggers. Small vessel vasculopathy, or disease affecting blood vessels, pathological accumulation of collagen, and autoimmunity causes disease manifestation. Tissue damage occurs when mononuclear cell clusters in tissues such as skin, blood vessels, and organs, stimulating lymphokines that stimulate pro-collagen, causing insoluble collagen formation in excess. The inflammatory response causes edema, which leads to fibrotic changes, causes loss of elasticity and movement. Eventually, the tissue degenerates and becomes non-functional. Scleroderma is divided into two main categories. So there's localized and systematic. Localized leads to morphia, which is isolated patches of hardened skin. Lineoscleroderma is lines of thickened skin affecting the tissue beneath. And scleroderma en coupe de sévère is thickened skin on the head. Localized scleroderma does not typically affect internal organs. Systemic sclerosis is divided into the categories of diffuse and limited. Clinical manifestations of diffuse or limited systemic scleroderma may involve skin, lungs, heart, kidneys, and musculoskeletal system. Skin manifestations are the patches of the thickened skin, sometimes accompanied with itching, especially in early stages. Patients with pulmonary involvement may experience dyspnea, non-productive cough, and pulmonary fibrosis, and have an increased risk of lung cancer. Conditions related to cardiac involvement include pericarditis, pericardial effusion, myocardial fibrosis, heart failure, and arrhythmia. Proteinuria and impaired renal function are common with renal involvement. The musculoskeletal complaints include swelling of the hands, joint pain, muscle pain, and fatigue. There's also digital ulcers, hypertension, decreased range of motion of joints, poor nutrition, frequent heartburn, and dysphagia. Three important manifestations of systemic scleroderma include Raynaud's phenomenon, scleroderma renal crisis, and pulmonary arterial hypertension, all of which are due to abnormal vasoconstriction of small vessels and as a result of functional changes in the arteries. The diagnosis of scleroderma is supported by the presence of clinical manifestations and serum antibodies. Laboratory testing may confirm a diagnosis of scleroderma, but is non-beneficial in excluding the diagnosis. Common laboratory tests include the ANA, which is the anti-nuclear antibody. Then testing for specific antibodies, such as anti-SCL70, anti-centromere, anti-RNA polymerase III, and anti-beta-2 glycoprotein 1. More than 95% of scleroderma patients have at least one of these antibodies present. Radiographical testing may reveal subcutaneous calcification, distal esophageal hypomotility, and pulmonary fibrosis. Pulmonary function tests are important to assess the vital lung capacity and lung compliance. Echocardiograms should be done routinely to assess for pulmonary artery hypertension and myocardial involvement. Before treatment is initiated, more invasive tests such as bronchoalveolar lavage and right heart catheterization may be required for definitive diagnosis of interstitial lung disease and pulmonary hypertension, respectively. Kidney biopsies are required to accurately diagnose renal disease. There is no single treatment for the management of scleroderma. So scleroderma, this is a really bad disease. If it affects your heart, it's going to fibrose basically and stenose and eventually lead to arrhythmias and death. If it affects your lungs, it's eventually going to lead to enough fibrosis that you're going to have lung damage where you're not breathing effectively. This disease is very sad on the systemic level. So obviously there's no single treatment because it affects everyone different. If you just have a patch of collagen on your skin where it's, a thick patch of skin, that's going to be very different than if it's affecting your heart or your lungs or your renal system. So, systemic steroids such as prednisone suppress the immune response by reducing the migration of leukocytes and reducing the activity of the lymphatic system. Immunosuppressants such as methotrexate work by modulating the immune responses to decrease inflammation. Antihistamines like loratadine or cetirizine may alleviate pruritus by blocking H1 receptors on effector cells. Topical ointments and moisturizers are used to help soften the skin and relieve itching. Vasodilators like amlodipine and nifedipine are used to improve circulation and treat Raynaud's phenomenon, pulmonary hypertension, and renal impairment. Treatment is focused on specific organ involvement and clinical manifestations. There are many possible complications related to systemic diffuse scleroderma. This includes infection, renal failure, heart failure, pulmonary fibrosis, and death. Complications must be addressed by healthcare providers based on the system affected and the degree of involvement. Systemic lupus erythematosus, SLE. So patients who have a relative with SLE are at higher risk than the general population for developing the disease. There have been genes identified that predispose humans to SLE, and females have it more than males at a ratio of 3:1. SLE is a chronic inflammatory disease that can affect virtually any organ system. The exact etiology is unknown, as it is the case with other autoimmune diseases. But the disease is triggered by multiple factors. Triggering factors include pregnancy, exposure to sunlight, illness, major surgery, silica dust, and medication allergy. Most clinical manifestations of SLE are attributed to antibodies and the creation of immune complexes that are deposited into tissues. Clinical manifestations are diverse and do not follow a specific clinical pattern. They vary greatly from one person to another. Typically, SLE involves periods of remission and acute disease flares. The nurse might identify the following during a flare: fatigue, difficulty concentrating, joint pain, rash. On the face, they call it a butterfly rash, which is it goes across the cheeks over the bridge of the nose. Photosensitivity, oral or nasal ulcers, dry eyes, dry mouth, malar rash, hypertension, leukopenia, and thrombocytopenia. Diagnosing lupus, like the other ones, can be complicated and frustrating. So there's no specific test used to diagnose this. Laboratory findings are used to support or confirm the diagnosis, combined with patient history and the physical exam. The lab testing is used to confirm some of the clinical and immunological criteria. So first, the testing is done to confirm the presence of autobodies. Patients with SLE produce the anti-nuclear antibody, which is ANA. They confirm the existence of autoimmune disease. The presence of an ANA itself does not diagnose lupus because approximately 2% of healthy individuals have a positive ANA. Non-pharmacological therapy, so this includes avoiding prolonged sun exposure and using sunscreen. Must be SPF 50 or higher and on a daily basis. A well-balanced diet is recommended for proper nutrition. Frequent rest periods and a regular sleep schedule help combat fatigue. Regular exercise improves strength and maintains range of motion. Give me 1 second, I lost my place. And we also want them to maintain a healthy weight. Pharmacological interventions for patients with SLE are typically based on the disease manifestation. So they might do hydrochloroquine, which is that anti-malarial or DMARD drug. This is frequently used to treat patients with SLE. The exact mechanism of action of hydrochloroquine is not fully understood, but it's believed to impair complement-dependent antigen-antibody reactions. Hydrochloroquine is also useful in treating constitutional symptoms like fatigue, as well as skin and joint symptoms. It helps to prevent disease flare-ups and serious organ disease that lupus can cause, like lupus nephritis. The most common side effects of hydrochloroquine are abdominal pain and nausea, which may improve over time. NSAIDs like ibuprofen are useful in treating arthralgias, myalgias, headaches, and fevers. Glucocorticoids can be used. These suppress inflammation in the joints, kidneys, and other systems. Immunosuppressive agent like methotrexate may be necessary to help with the joint inflammation if it doesn't respond to the NSAID or the steroids. Let's see. Ballista is a modifier that was approved in 2011 for the treatment. This is a monoclonal antibody that binds to proteins like BLYS, and it interferes in the inflammatory cascade, decreasing the immune response that is responsible for causing clinical manifestations of SLE. Surgical intervention, so this is renal transplant for patients with severe lupus nephritis, joint replacement for patients at risk for avascular necrosis. So again, lupus, it's a chronic disease that has a lot of complications. So your renal failure, premature heart disease, lung disease, hypercoagulation, stroke, avascular necrosis of joints, increased risk for infection. So complications that can arise is toxicities related to the pharmacological therapy as well. So we want to focus on patient teaching of the disease process, using sunscreen daily, conserving their energy, and prioritizing activities. We want them to stay up to date on immunizations, but we need them to avoid live vaccine. Avoid oral contraceptives in patients with SLE who have migraine headaches. They might have Raynaud's phenomenon or a history of phlebitis, antiphospholipid antibodies. Patients with SLE, specifically patients with the manifestations noted, have an increased risk of hypercoagulability. So if they use oral contraceptives, it can increase the risk of a blood clot. And that is all I have on lupus right now. So gout. Gout affects approximately 2% of people in the U.S., and it's commonly found in men aged 40 to 60, women aged 55 to 70. Risk factors are obesity, hypertension, eating large amounts of meat and seafood, thiazide diuretics, and consuming large quantities of alcohol. When metabolized, purine-rich foods like seafood, meat, and alcohol increase uric acid production. Thiazide diuretics like hydrochlorothiazide increase the net urate reabsorption in the renal tubules, therefore increasing the serum uric acid level. Gout is a disease in which monosodium urate crystals are deposited in joints, bone, and soft tissue, accompanied by inflammation. Hyperuricemia, which is an elevated uric acid level in the blood, must be present prior to the evolution of gout. But the presence of hyperuricemia is not indicative of gout. The body's attempt to rid itself of the crystal deposits result in an inflammatory process that causes swelling, redness, warmth, and intense pain in the joint affected. There will be a decreased range of motion and decreased function in the area of the joint affected. Gout attacks typically resolve after several days or weeks, even without treatment. However, gout can become a chronic inflammatory destructive arthritis. There are 3 phases of gout: acute, intercortical, and chronic. Acute gout usually involves one joint and is characterized by acute onset of pain, redness, and swelling. Intercortical gout is the asymptomatic period between gout attacks. If gout is left untreated, the attacks may become more often with a shortened intercortical period. Chronic tophaceous gout is characterized by repeated attacks over many years, leading to the production of tophi. Tophi is uric acid deposits or nodules in the joint, and joint destruction. 80% of patients that present with the first attack of gout affect the lower extremities, typically the first metatarsophalangeal, which is that big toe joint. The severity of the attack typically peaks at 12 to 24 hours after onset. So treatment. Non-pharmacological treatment consists of weight management because obesity is a modifiable risk factor for gout. Alcoholic beverages, specifically beer, need to be avoided because they increase uric acid production. Splinting of the affected joint may also be useful in protecting the joint and alleviating pain. Pharmacological treatment depends on which state the patient is in when requesting treatment. Acute gout management is focused on pain relief and reduction of inflammation. Common medications are NSAIDs like indomethacin and colchicine. These decrease the buildup of uric acid crystals in the joint. Glucocorticoids are used to reduce inflammation and provide pain relief. Management of intracortical gout consists of the use of NSAIDs and colchicine, whereas managing chronic gout focuses on the use of uric acid lowering agents. Uric acid lowering agents such as allopurinol reduce serum uric acid by inhibiting the production of uric acid. One very important fact to remember is that acute gout is never treated with uric acid lowering agents like allopurinol. For unknown reasons, a rapid change in serum uric acid level may provoke a worsening gout attack. Complications are kidney stones. Urate crystals can aggregate to form a stone, making outpatients more likely to experience kidney stones than the general population. And there you have it on gout. Fibromyalgia. So this is a common, it's commonly found in patients with rheumatic conditions like RA, lupus, and Sjögren's syndrome. The onset of fibro usually occurs in the middle adulthood, but it can occur in adolescence and later in life. Genetic factors may play a role in predisposing patients to the development of fibromyalgia. So fibromyalgia is a chronic pain disorder of soft connective tissues, and it's characterized by widespread pain and other symptoms like insomnia, fatigue, stiffness, and cognitive dysfunction. The etiology and pathophysiology of this disorder are unclear, but current theories include the abnormal processing of stimuli by the central nervous system, causing normal pain signals to be amplified. The amplification of the stimulation causes fibromyalgia patients to feel pain, whereas those without fibromyalgia would not feel pain. Fibromyalgia may be triggered by an infection or physical or emotional trauma. In females, the menstrual cycle can affect sensitivity to pain. Normal daily stress combined with common fibromyalgia symptoms can create a cycle that builds one on another. The book has a great picture on this cycle. Laboratory testing is not necessary to diagnose fibromyalgia, but may be necessary to rule out other diagnoses. History and physical assessment are used to diagnose fibromyalgia. Patients often report hurting all over or feeling as if they have the flu. Other complaints include fatigue, headaches, cognitive impairments, and abdominal pain. The physical examination of this patient is essentially normal. There's no evidence of joint or muscle inflammation. Non-pharmacological therapy includes physical therapy, strength training, aerobic exercise, cognitive behavioral therapy, education, and self-management. Physical therapy is helpful in maintaining strength and function. The cognitive behavioral therapy may be used to help understand the illness and change patients' behavioral response to the pain. Self-management skills include utilization of relaxation techniques to minimize stress, establishing regular sleep patterns, and exercising regularly. Pharmacological therapy includes medications that alter chemicals in the brain like serotonin and norepinephrine, or block overactivity of nerve cells. Other medications that may be used are those that improve sleep and treat pain. Non-steroidal anti-inflammatories, antidepressants, and anti-seizure medications are commonly used to treat fibromyalgia. The use of opiate analgesics is not recommended because they may be habit-forming and they're usually ineffective. Patient teaching. So we need to teach our patients to take the medication as prescribed. Participate in regular physical activity. This will help maintain or improve strength and function. We need to help teach effective coping skills because this is important to maintain a positive attitude and improve self-concept. Assist with referrals for a sleep study. Ineffective sleep can increase pain and fatigue. Refer them to a mental health facility if necessary. These patients often have depression related to the chronic pain. And referral to OT and PT as needed, as well as compliance with a healthy diet and exercise regimen. Getting adequate rest and taking care of mental health is essential to managing fibromyalgia. We need them to take medications as prescribed and, whoops, one second, please. A well-managed patient has decreased pain and fatigue, healthy sleep patterns, and maintenance or improvement of strength and function. So basically, you're going to help assist them with referrals. Understand this is a rule-out diagnosis, so they're going to rule out everything else before they give this golden diagnosis. There's no specific treatment, but we usually are doing medications that are more antidepressants, anti-seizure medications for these patients. And that's going to wrap up this PowerPoint. We will talk more in class about these different diseases. Thank you.